Well, welcome everyone who's watching in the community here in Montgomery County and maybe a little bit beyond. Anybody obviously has access to this all over the nation, all over the world. But welcome to our very first virtual Lunch with the League of Montgomery County, Indiana. We are so delighted to bring this program to you at a special time in our nation's history. As always, League is dedicated to making sure citizens have as much information as they possibly can to make the best decisions as active citizens. As most of you know, but which always bears repeating, the League of Women Voters is a nonpartisan organization dedicated to informing citizens about vital issues of public concern and encouraging us all to be registered voters, of course, and active participants in our local government. League of Women Voters came into being 100 years ago this very year on Valentine's Day, 1920, and its vital work continues unabated. League is kind of like the air and water of our democratic process. People count on these things that the League does, but we hardly remember that people are doing them. So thank you for tuning in today as we do an interview here with our county health officer doctor and also with the head of Montgomery County's health department here right in the midst of the coronavirus pandemic. Thank you all for coming. So Dr. Scott Douglas, this is Mark O'Dees.
All right, so welcome guys, and as Helen said, thank you so much. We really appreciate your time. This is certainly an interesting time in our lives, and you making the time for us to help illuminate some things. It's very beneficial, and we really appreciate it. So number one, Dr. Douglas, is just some background for those who may not be up to speed or confused or just unaware. What is going on? Where did this come from? Where are we at?
Well, first of all, thanks for having us. The coronavirus is a family of viruses that have been around for a long time, and a coronavirus circulates from time to time, and usually are not serious, and usually there's some underlying immunity within the society, within the population. But there have been some versions of the coronavirus that have been particularly virulent. One called SARS, which was a severe acute respiratory syndrome. And that coronavirus rose up in about 2002 in China. Another version called MERS, which was Middle Eastern respiratory syndrome caused by the coronavirus, had an outbreak in the Middle East in about 2012. What is unique about this virus, and as you might recall, we call it this novel coronavirus, and what that means is that it's different enough from any of the other coronaviruses that have circulated that almost nobody has immunity to it. And so that's the fear, and that's also why it appears to have spread so rapidly across the globe, is that there is not any underlying immunity among populations of human beings. And so not only is the population at risk, but healthcare, as you've been aware, is not immune to it either, which is different than, for example, influenza, where we vaccinate all of our healthcare providers so that healthcare providers can take care of you when you get sick with influenza. We don't have that ability to vaccinate for the SARS vaccine, or for the SARS virus. So this virus, just to get everybody up to speed, first appeared in Wuhan, China in December. It spread pretty rapidly. We had our first cases of that virus in the United States in January. And in Indiana, we had our first case March 6th. It is, I think, completely astounding that a virus that welled up in December has spread around the entire globe in just less than 3 months. The fear of public health that we've all been hearing is that because everybody is susceptible to the virus, and the virus appears to be pretty contagious, is that if lots of people get the infection at the same time, it would overwhelm our healthcare delivery. We wouldn't have enough hospital beds. We wouldn't have enough ICU beds. We wouldn't have enough ventilators to take care of high numbers of people getting infected at once. And that's what led to the stay-at-home orders that now nearly every state in the country has adopted. And the whole idea is to keep us from transmitting this contagious infection to each other, so that we can manage those who do get sick without being overwhelmed in the healthcare system. And that's where we are now. And it does look like we're being successful in slowing down the spread of the virus. And one way we look at that is in what is the doubling time of the virus. And that means what length of time does it take for the number of cases to double. And before the country started implementing a lot of the stay-at-home orders, our doubling time on the virus was about 3.3 days. In other words, every 3.3 days, the number of cases doubled. But once we implemented the stay-at-home guidelines, with the social distancing, fewer people were transmitting the infection, and the doubling time then spaced out to about 5.4 days. So it has been very effective. And also, all of our models about when are we going to peak and how high are our peaks going to be in terms of the number of people getting infected, all of our models have, which initially looked very grim, have really all started to reflect the fact that we are doing a good job. And one of the keys is we've got to keep it up. Because this fact is still that most of us have not had the infection. And those of us who are susceptible to the complications of the infection, those who have underlying serious medical problems, heart disease, lung disease, kidney disease, diabetes, immunocompromising conditions, chemotherapy, for example. All these folks still have not had the infection, and most of us have not had the infection, and we are at risk, if we are not careful, to have this well up and start costing more lives. So we still have to be careful, and this is going to be an ongoing battle. It's not going to be over this spring, because we believe that this virus is not going to go away on its own. And like other viruses that plague us as humans, we've had to resort to vaccines to help prevent them. And that may be our saving grace of this outbreak, is the development of a vaccine. But that's not going to be quick. It's going to take some time.
Very good. Okay. So regarding the social distancing, the guidelines, the lockdown type quarantining stuff we've been doing, you mentioned. So I've noticed that this is escalated just in the last few weeks. It feels like the CDC has recently said that now everybody should be wearing masks, things like that. Or it feels like there's more and more. Where are we at on things like that? Hiking, masks, things like that?
Well, first of all, we think it's primarily spread through respiratory droplets. And respiratory droplets are what come out of our mouth or our nose when we cough or when we sneeze. And these droplets in general are fairly heavy, so that they settle down pretty quickly. And that's where that 6 foot distance came from, was when we cough or sneeze, those respiratory droplets don't tend to travel beyond 6 feet before they kind of settle down. We also, and so we can catch the infection by inhaling those or touching objects that those respiratory droplets have fallen on and then handling our face. And that's where you get those guidelines about trying to avoid touching your face. The recommendations in terms of the mask is not so much to wear a mask to protect yourself, but to wear a mask to protect those around you. Because when you cough or sneeze, if you have a mask on, you limit how much of that virus gets spewed out into the environment. So a mask is not so much for your own protection, but it is a kindness that you do for those around you. Now, in terms of being outdoors, the procedures that aerosolize the virus, that's aerosolization is a little bit different than these respiratory droplets. It's a finer mist, maybe as a way to describe it, that may have the virus in it. And that's more of a risk in a confined space, in a home, or particularly worried about those aerosols in a hospital setting where they're doing procedures that may stimulate more aerosols, like intubating somebody, putting a tube into their lungs, or resuscitating somebody who's had an arrest. That seems to aerosolize that virus and fills the room with the virus. And so there's so much concern about healthcare workers in that kind of setting. But when you're outdoors on a hike or on a walk, we really feel that if you're maintaining social distance of at least 6 feet, and maybe if you were concerned, extending that out to 9 feet would be certainly reasonable. We really think that your risk is very low when you're outdoors, with or without a mask. We're all afraid to say that the risk would be zero, because we don't believe that. I mean, we realize that there's a little bit of risk in everything we do. There's probably some risk that you incur when you're driving out to the park in your vehicle, in terms of having a motor vehicle accident, or other kinds of risks that we're always exposed to. So you have to look at it as, what's your risk? And we feel that from the public health standpoint, we feel that the health benefit of getting outdoors and walking and exercising, that health benefit exceeds the very tiny health risk that you're going to catch the infection from somebody when you're exercising outdoors.
At a great distance.
I'm sorry?
Certainly at a great distance.
Yeah, and I did see some data or models about running or jogging, and of course, if you're 6 feet behind somebody but they cough and then you run into their droplets, you might be 6 feet away when they coughed, but you just ran into it.
Right.
So if you're on a jogging trail and you're following in line with other joggers, you're going to want your distance to be more than 6 feet. So that's sort of a different situation than, say, hiking outdoors.
Okay. So hiking, getting out, walking, I assume you're getting out then? That's reassuring.
Mm-hmm. Yeah. I've got dogs. I take them out and walk the dogs. We view exercise as an essential human activity. We know in terms of health that if we don't get exercise, our health suffers, and so that's something that we don't want folks to stop exercising. Now, exercising in a gym with other folks would not be wise, and those gyms are now closed for that reason. But getting outside and running or jogging or a good brisk walk or bike riding, we feel like those are things that we ought to continue to do. This is going to go on for a year. We've got to continue to take care of ourselves.
Sure. So I want to get back to something you mentioned about the masks. So you said wearing a mask is more about protecting the others around you than it is yourself. So this sounds very much like the vaccine herd immunity type thing, where certainly you may not be the one who is at risk of dying from influenza because you're young and healthy or whatever, but getting the vaccine is more for the benefit of your elderly neighbors, your grandmother getting chemo, that kind of thing, right? So it's about social responsibility.
Yeah, and we see that, there's, folks sometimes want to argue that they don't want to vaccinate their children, for example, for chickenpox. They say, hey, I was a kid, I got it, I survived it, look at me, I'm doing fine. But we want to point out that there's a lot of folks in the population that would not do fine if they got chickenpox. And the way we keep the chickenpox out of the population is to vaccinate. And that's to protect everybody.
Okay. So as these numbers have been evolving quite a bit, just day to day even, what is the current mortality rates and statistics by age group and et cetera?
Well, first of all, our data is not very good. And the data is not very good right now because we are under testing. We wish we could be testing more. There have been some significant shortages and lag in the United States in terms of getting testing ramped it up. So when we're looking at mortality rate, the mortality rate is what percentage of folks who have the infection will die from it. Well, if we don't know what percentage of the population has the infection, then it's hard for us to calculate what the fatality rate is. It does appear that the fatality rate is higher than the fatality rate with influenza. Our fatality rate with influenza is somewhere around 0.1%. We think that the mortality rate of COVID is probably going to end up being around somewhere between 1% and 2%. But it's still for us just far too early to figure that out. But from a public health standpoint, a 1% or 2% fatality rate on a virus that we're all susceptible to is alarmingly high. And I think folks sometimes look at that number and think, oh, good, it's only 1%. Well, from the public health point of view, we think that's not very good, and
Sure.
We're pretty worried about that.
Yeah, 1% of millions and millions of people is a pretty big number.
Mm-hmm.
Okay. So really, we just don't have the metrics. I mean, yet we don't. I mean, it's going to be about surmounting the testing availability. When do you think we'll cross that hurdle of having almost complete access, adequate access to testing kits nationwide?
I think probably within the next 3 or 4 weeks. That has actually been ramping up pretty quickly. Commercial labs have started coming online very rapidly, primarily because of an emergency use order by the FDA, which allows the labs to establish or to put together a test without jumping through all the hoops that are sort of required to test and confirm and validate a test. And so the commercial labs have really stepped up, and so they're available for testing far more specimens than just even 2 or 3 weeks ago. Our other issues are the supplies necessary for testing. That is this transport media that when we collect a swab of the nasopharynx of a patient that we're testing, that swab has to go into a little test tube of transport media that so that it can be transported to the lab for testing. There's been a shortage of that transport media nationwide, and especially we've had trouble in Indiana with that. But there again, that availability is starting to increase as commercial labs and the healthcare industry has started to kick in and make more of that. So in terms of the nasopharyngeal swabs that we do, that check for the virus itself, that's going to ramp up pretty quick. And other types of testing is also increasing, and we still are sort of in the infancy. But one way that we test for infections is through blood, and this is not something new. This is something that we have done for a long time. For example, we will sometimes test somebody if we are not sure if they've been fully vaccinated for measles or mumps or rubella. We have a blood test that tells us if the patient has an antibody sufficient to protect them from those viruses. We'll be able to do the same thing with the coronavirus. We'll be able to check blood for antibodies to determine who might already be immune because of having been exposed to the infection or having had the infection. That is also ramping up pretty quickly. We need more data on that because we don't know for sure yet how long immunity will last. If you get sick, we don't know how long you'll be immune. We also don't know what level of antibodies that you might need to confer immunity. But there are companies now already putting kits together, tests together to test antibodies. That's going to be particularly helpful as we move forward. It's going to be very helpful to know which healthcare workers have already conferred some immunity. It's also going to be particularly helpful when we're looking at school systems or nursing homes, when we have populations that are gathered together in close quarters. It's going to be very helpful for us to know who's already immune and who do we need to segregate if there looks like there's going to be an outbreak, or if we're starting to see an outbreak. It allows us to respond much more efficiently if we know who we have to target our quarantines on, for example.
So you got into another question I have there. It sounds, one of my questions was going to be, are you, once you have it and have gotten over it, are you immune? And it sounds like the answer is kind of maybe. Moving beyond that, though, even I would ask, can we expect this to be kind of a flu type evolving virus every year moving forward, where it's a new version every year?
Yeah, I don't know. I have seen reports that there have been a different sort of genomic strain of this virus early on, but I don't know what that's going to mean going forward. I've not heard public health talking about this in a way that that the virus is mutating rapidly. So this is going to be something different. You know, one of our battles with HIV, for example, in terms of coming up with a vaccine to treat HIV, which is a virus, is that virus tends to sort of mutate and evolve and makes it very difficult to have a vaccine that works for it. So, but I've not heard that kind of talk from the public health community that we're going to have that kind of problem with the SARS virus. So I think that's fortunate because it gives us the opportunity to make a vaccine that hopefully will help us down the road in terms of preventing folks from getting the infection.
Sure. So you mentioned, and we've heard on the news from every source, and can kind of presume, I guess, that the elderly, the immunodepressed, those are the greater risk people, based on the very limited, as you said, the metric. I understand the metrics aren't complete, but based on the limited data we have, is that still holding very true?
Yeah, yes, that's true, and that's always been true, even when we're looking, for example, at influenza. Our elderly who have more underlying medical problems, heart disease or COPD, other kinds of lung problems, where they may get a cold, and that may make them very sick just to get a common cold because of their already underlying medical problems. And so their ability to tolerate an upper respiratory infection is already compromised. So when they get any bug that comes down the pike, they're going to be more susceptible to having a complication from it. And that's one of our fears, for example, in a nursing home setting, when we have really a congregation of people that are already compromised in terms of their health. The fatality rate, as you can imagine, is higher in those over the age of 80, for sure. In patients under the age of 50, the mortality rate is really quite low unless they already have a very serious underlying medical problem. But that's sort of not unique to this virus. It's just one of the facts of life with all of our viruses is if we already have underlying problems, this can be the straw sometimes.
Sure. Well, and we all know, everybody has an elderly neighbor. Everybody knows someone who is either going through treatments or some such issues like that. So, it gets back to the social responsibility thing. We're all in this together. So that's a good note for our viewers. Everybody, make sure even if you're 25 and very healthy, make sure you're looking out for everybody. So here in Montgomery County, who is the contact team for tracing down the leads? If someone is tested positive, who tracks that back to patient 0 of Montgomery County or whatever and tries to take action there?
Mm-hmm. Well, like every county in Indiana, we have, each county in Indiana has a health department, and the health departments are staffed with nurses, depending on the size of the county, how many nurses they have. Montgomery County, we have 1 nurse. And when we get a positive case, we immediately start looking first to see who took care of them from the medical point of view. We feel a responsibility to contact the EMTs, for example, that might have transported that patient by ambulance. We contact the emergency room if they had contact there, so that we can identify what healthcare people interacted right away with that patient, so that we can prevent those healthcare people from transmitting the infection to somebody else who's vulnerable. Fortunately, EMS, our first responders are really now well versed at figuring out if they need to put on their protective equipment to prevent themselves from being exposed, and so that helps tremendously. We can keep them in service if they've worn their equipment. But every once in a while, especially early on, we had issues with folks who didn't look like they had a respiratory problem. Maybe they called the ambulance for a heart problem, and our folks didn't necessarily don all of the equipment that they needed to, and then later we found that the patient had the virus, and so we would have to contact those transporters and take them out of service. They had to go into quarantine like everybody else who's been exposed has to be on a quarantine. So we do that first, and then the nurse starts focusing on the contacts of the patient in their own home, and also the contacts that they may have had at work. And the folks that have had direct contact with a positive case, we identify who those people are, and we put them on quarantine. And quarantine is a term we use when somebody has been exposed, but they're not sick. So they have the potential to get sick, and they have the potential to get sick during that time that we call the incubation time. And that's the time that it takes from being exposed to a virus for that virus to start growing and replicating and getting to a point where it may start to infect you and make you sick. So with this virus, the incubation time can be anywhere from 2 days up to 14 days. So when folks have been exposed, we put them on quarantine so that they don't, if they do get sick, that they won't expose other people unnecessarily. And that's different than isolation. Isolation is the term that we use when someone is sick and has potential because they are sick, they are infectious. And when somebody is in isolation, it's even more stringent than just being on quarantine. Quarantine, we ask folks to stay at home, don't go to any, don't go out of the home, stay away from other people. When folks are on isolation, they are isolated even within their own home because they are a threat to their own family. And when someone's on isolation, we encourage them to be in one room, to use one bathroom if they have that luxury of having just one bathroom that could be designated for their use within the home, to not expose themselves to other family members, to wear a mask when they come out of their room. I mean, so isolation is even more intense than quarantine. But this is probably our single most useful public health tool in terms of trying to prevent the spread of infectious disease, is identifying those who have the disease and isolating them, and then determining those who have been exposed to the disease and quarantining them.
Okay. So maybe I'm just not exposed to all the right information or what have you, but it feels to me, from my perspective, as though we've been pretty fortunate in Montgomery County in terms of the exposure, the numbers. It feels like, I'm not hearing as many here locally as, a lot of other areas. Are we lucky, isolated? Were we more prepared than other areas in the country? Are we doing something right?
Well, first of all, I think your perception is right. I think, for one, I think Indiana in general responded pretty quick in terms of a stay-at-home order, and I think that has really made a big difference. And it's made a big difference in all kinds of other diseases too. If you can imagine. If our kids aren't in school, they aren't bringing home the runny noses, the coughs. We're not seeing all the cases of strep throat that we would normally be seeing in the spring, right, with kids infecting each other. We're not seeing as many cases of gastroenteritis, which is the virus that can cause vomiting and diarrhea that we see off and on during a school year. Our folks that have COPD, who get sick every time they catch a cold, get sick and sometimes have to be on steroids or additional medicines or antibiotics, or if they're sick enough, end up in the hospital. We're not seeing those folks get as sick as often because they're just not as exposed to other people with viruses. So it's not just the COVID that's having an effect in our community, but we can see the benefit of the stay-at-home order, not just in decreasing the numbers of COVID cases, which I'm sure it has, but also we're seeing it reflected in a decrease in all these other viruses that we normally see.
Great. Are there any measures being taken locally to check in on like those at greater risk, just like house visits or phone calls? What is being done, if anything, to just check in on them and make sure that they're doing well during this time?
Well, and this is sort of outside of the scope of the health department because we don't have folks' medical records. We don't know who has what diseases, or that's kind of outside of our scope. But within the community, there is a lot going on, and in the primary care offices, for example, there's been real concern about not having folks who are vulnerable in our office, because as you can imagine, our waiting room could be a pretty hazardous, dangerous place for somebody who has an underlying medical problem. We don't want them to catch an infection by coming to see us. And so the local providers, early on, when we had appointments for our chronic patients, just started calling them on the phone and checking up on them. We called them phone check-ins. We knew they were on our schedule for an appointment. we felt that it might be too risky to have them come to the office, so we just started doing phone check-ins. And now that's evolving as payers, Medicare and Medicaid and commercial payers have quickly started realizing that we can't have diabetics out of check with their doctors, or folks that have heart disease or high blood pressure, that they still need care. So there's been a very rapid acceptance of video visits, virtual video visits, much like we're doing here. You sit down with your doctor, and the doctor, talks to you about your symptoms and about your medicines, and are you getting your medicines, and are you taking them as you should, and what are your blood sugars, and if you have a blood pressure cuff at home, what are you seeing on your blood pressure cuff? Let's make an adjustment if we need to right now. So that's going on, and that's becoming that's ramping up pretty quickly, especially in this week. You're going to start seeing within our community a lot more virtual visits, and that may stay with us for a while. Of course, there's always going to be patients that we need to see, that we have to listen to their chest, that we have to lay hands on to really make a diagnosis. But there's going to be a lot of work that we do that we can do virtually, and that's going to continue. There's just a benefit to not exposing folks who are vulnerable to the general population, especially a doctor's office, when folks are coming in with illnesses.
Certainly, good note. So for those viewers who didn't know already, may not have heard anything about this, certainly it sounds like we're recommending ask your doctor, call first, email first, and ask about these options. That's good stuff.
If your doctor hasn't reached out to you, there's nothing wrong with calling your doctor and saying, hey, I know we canceled my blood pressure check a couple weeks ago. Is there, do we need to have a visit, and can we do it online?
Yeah. As troublesome as technology can be for some of us sometimes, it's one silver lining about this whole situation is we do have a lot of alternatives and opportunities as well. So we're very fortunate in some other ways. So,
yeah, we're learning on the fly, but I think some of these things that we're learning are going to stick with us. I think we're not going to give up virtual visits in 3 months. I think that this is going to be a technology that we learn to use and use more efficiently.
Right.
And it's going to be with us.
So regarding local businesses and industry leaders, what kind of contact have you had with them? Do you feel like they've reacted appropriately? Are you giving them any guidance? Have they had to change their habits significantly, schedules, things like that?
Well, of course, the businesses that aren't essential are closed. But early on, we fielded a lot of phone calls from local businesses with questions about, what should we do with somebody who's got a cough or a runny nose, or what should we put in place in terms of monitoring our folks that are coming to work. And then there's been a lot of guidance from the Indiana State Department of Health that's online, that's to industry, in terms of how to maintain a healthier workforce. And we've directed folks to that website, as well as the CDC has a lot of information. I think our local industry has been overall, I think, pretty responsive and responsible. And early on, I think there was maybe a little bit of even more aggression than we needed, which was perfectly okay in terms of early on. We had a couple plants who were going to require their employees to have a negative COVID test to come back to work when they'd been sick. And we had to reach out to them and say, that would, in a perfect world, in the best of all possible worlds, that's what we would want, would be to test somebody to show that they were well before they go back. But we just didn't have that capacity to do that. And so they were being very proactive. And then we had to say, we agree with you, but we can't do it.
And to find a balance.
Yeah, well, we just didn't have enough testing supplies to be able to test people. You know, we were still worried about having supplies enough to test people that were sick enough to be in the hospital, let alone test people who are well. And now we want to show that they're well. So that kind of testing is going to be pretty far down the road in terms of doing those nasopharyngeal swabs. Now we may be able to, down the road, use the blood test to show that somebody has immunity. And that's going to be really helpful, I think, for everybody involved to know who's immune and who's still susceptible.
So regarding essential business, local business and essential business, and specifically like the restaurants, the mom and pop shops, a lot of us, I've noticed on social media, a lot of people, myself included, were trying to continue to support those companies, those small businesses, and do like pickup and things like that. What if anything, are there any concerns, you know, for, should we be wiping down a cardboard box, or I mean, how do you, there's probably you can probably go too far, but you know, these are the things that we're all thinking about now.
Mm-hmm. Yeah, where do you stop? And it's all, of course, this idea of risk and benefit and how big is the risk. Of course, if we never ate out, never had any interaction with any other person, if we live completely solitary, why, we probably wouldn't catch any infections from anybody. But that's not realistic. We have to eat. We have to be fed, and so you know, we rely on the produce that we buy at the grocery and on the foods we take off the shelf at the grocery, and we rely on food that we pick up from from takeout, we do know the virus, it can live on other surfaces. It doesn't live as long, for example, on cardboard or paper as it does on like a metal surface. The likelihood of catching the infection from groceries or packages or takeout is really very low, and so we don't think that you need to start wiping down your boxes. We do encourage folks to wash produce off, but not just because of the COVID virus, just because of other chemicals that might be on the food that's worth washing off, insecticides or herbicides in the production of food. Makes sense to rinse off produce before you prepare it and consume it. And on takeout, just simply washing your hands when you've handled things, put it in your cupboard. We don't think the virus lives for more than a few days. So, if you unload all your groceries and stick them in the cupboard and you wash your hands afterwards and don't touch your face, as the recommendations are, your likelihood of catching the virus from your packaging is just very low.
You made a great point there about the washing your produce, but you should probably wash your produce anyway. On a related note, I got to say, we should be washing our hands anyway, and sneezing into the elbow. These are a lot of things. I think it maybe hopefully a wake-up call. I can't tell you, in the last 5 years, I've seen people just sneeze right out into the open in a public place, and I just cringe. And this is pre-COVID, so hopefully this is a wake-up call for a lot of people.
Well, it'll be interesting to see if we resume handshaking. That's how we spread influenza. That's how we spread colds. And
I'm very much of the opinion that I think I'm done with the
yeah, I think it'll be, yeah, I think that this is a turning point in our culture in terms of how we're going to greet each other. And I just think it's so, when you have a virus like the COVID, which spread across the globe in 3 months to the whole entire world, it really is a wake-up call. Is, you know, we have to start thinking about our vulnerability to infections like this, and very simple things that help decrease transmission.
Sure. So regarding schools in the area, it feels to me like that's been one of our more successful, like really a feather in our cap in terms of the reaction time and the precautionary measures that have been put in place. Where are they at in local schools? Where are they at in terms of scheduling? And do you think this will be, like a lot of other things we've been discussing, a sweeping, moving forward change of more technology, things like that?
First of all, I want to say that in Montgomery County, our local school systems, all three of them, responded very efficiently and very rapidly to the threat of the coronavirus. In fact, they made a decision to close schools before the public health in the state of Indiana made that sweeping recommendation. And so my hat's off to them for being proactive. And I think that, by the way, I think that may have been one of the important things that happened in Montgomery County that may have helped us in terms of the county and the number of cases that we've had, is that very early on, before the before the school system's spring breaks, closing. And I think maybe down the road, when the dust settles and epidemiologically we can go back and look at what things helped and what things didn't, I suspect that we will find that decision by our school systems was one of the critical things that happened in Montgomery County.
Agreed. Do you think we will ever be back to 100% normal in terms of going to the movies and going to a football stadium and not worrying so much about wearing masks or what have you?
Oh, yes, I do think we'll end up getting back to that, getting back to our normal crowds, the things that we enjoy doing together in groups. It may be a few years, it may be a couple years before we're completely back. I think we will gradually, over the course of this year, start easing up on our social distancing. But I think probably for the next 12 to 18 months, I think it's not going to feel like it used to.
Fair enough. So is there anything you would say to people who have continued about their day-to-day totally unaffected or seemingly unaffected?
Yeah, we don't do very well as a solitary animal. Human beings are, we're communal. We live in community. And when we ask people to isolate themselves, it is very difficult. And so we recognize that. And sometimes our socialization occurs in the store, especially those who are living by themselves. When else do they see their neighbors? It is very difficult, and we recognize that. But there are folks that seem to not agree, maybe for lack of a better word, with our public health recommendations, in that, just as you said, they may say, well, that virus doesn't seem to be that bad, and if I get it, it doesn't seem like I'm all that worried because I don't have any medical problems. And that is distressing to me, because I think it's a lack of understanding of of what we have to do for each other. It does seem to me like a very selfish point of view. But we also realize that we don't motivate people by calling them selfish. We try to motivate people by example, and by praising those who are complying. And in Montgomery County, by far the majority of folks are complying. And in fact, that's something that I've been really very optimistic about, is how well folks have taken it seriously. And it's those who are taking it seriously that have really, in my view, kept us from the brink of catastrophes, in terms of having overwhelming numbers of people sick at once. If we weren't doing this distancing, I think we would be in trouble.
Good. Note of optimism.
Yeah, and I do think, this whole pandemic is it is forcing us to look at ourselves and to look actually at what's important, and to look beyond ourselves and to start thinking of others maybe more than we have in the past. And I know I've started thinking more about my neighbors, and realizing that I've got some neighbors that probably need somebody to go to the grocery for them. Yeah. And that kind of thing that I would have not thought about before, I'm now thinking about. And I think that's true about everybody in Montgomery County. You're starting to think about other people, and things that you thought were important, you're starting to realize, you know what, that wasn't so important. There's other things that are more important, and the well-being of those around us becomes more important. And
so another self-reliance, a greater sense of community.
Yeah, I think so.
That's great. Well, that's all the questions I had prepared. Do you or Amber, do you have any final thoughts? Anything you'd like to add?
I do want to add something, and that is the hard work of Amber Reed and the Montgomery County employees in the health department, who have been very busy and working through the weekends, coming in, on days when they wouldn't have normally been working, to put in extra hours for the benefit of the county. So we're very blessed. And I should also say that Montgomery County, for many reasons, I think is in far better shape than a number of surrounding counties. I think the health department had plans in place already in terms of how to manage a problem like this. Our mayor of Crawfordsville, with a background in emergency services, having been a fire chief, understanding what a community needs to have in place to deal with an emergency, I think that positioned Montgomery County much better. And so I think Montgomery County, I think, has come through this, or is coming through this in better shape than a lot of counties.
I have to agree, and thank you and Amber and everybody on your teams. You really are heroes. So we really appreciate it. You guys are doing great work.
Thank you.
Well, and I would also echo that Montgomery County is very fortunate to have Dr. Douglas. What he doesn't tell you here in this is that he is also a family care physician. So, and he's also the physician for Wabash College, and he's also the county health officer. So he's putting in a lot of time that nobody will ever see on all of those fronts. And he's still a husband and a father, and and a community member. And so we tend to forget. I shouldn't say forget. We wear a hat, and but then we have to put a different hat on when we go home. And we have those same concerns as a parent and as a child of someone, and a caregiver. So we've talked a lot about giving ourselves a little bit of a break and cutting some, ourselves some slack. And that's important. There wasn't a book written to tell us how to deal with this emotionally. So, that's one thing, but we're very fortunate. And we were lucky to get Dr. Roberts to kind of tag in on this as well. And he's been phenomenal in helping, and they were able to kind of work together. Well, they are working together through Wabash and as doctors in the office. So we're just really, really lucky. And I know that that's hard for some community members who aren't as maybe engaged or don't understand kind of what goes on in the background. But all I can say is we're just really lucky. So
I see that for sure. Yes, I feel very fortunate. Helen, would you like to jump in?
There we go. Should we all put on our masks? I think I saw you carrying yours, Dr. Douglas.
Oh yeah, I took it off because it didn't match my shirt. But
There we go. Thank you all so much for this really generous gift of your time. Greetings and best to all your families, and thanks. And we'll end with our beautiful new revived friendly wave to support, to replace our handshakes.
Absolutely.
Thank
Mm-hmm.
you so much, and may we all be safe and healthy. And again, thank you too for all your professional work. It goes beyond saying that it meant all the world to all of us that we have a nationally award-winning health department before we started this, and that John and Scott have worked together for decades together, and both Wabash grads. It's a beautiful sign of the depth of what our community is. So thank you all so much, and farewell.
Thank you all.